So this is an update on the treatment of anaplastic thyroid cancer. And so Dr. Maria Cabanillas is an oncologist and endocrinologist, professor and faculty director of clinical research in the Department of Endocrine Neoplasia at the University of Texas MD Anderson Cancer Center in Houston. As a clinician and clinical researcher, Dr. Cabanillas treats both early and advanced thyroid cancers, including medullary, differentiated, and anaplastic. Her research focus is in advanced and aggressive thyroid cancer and molecular targeted therapies and immunotherapy. She is a principal investigator on several clinical trials for treating advanced disease and has been a member of and currently serves on the board of directors of the International Thyroid Oncology Group. She is also a ThyCa medical advisor. So with that, I welcome Dr. Cabanillas.
Okay, well, I think I need to update that introduction because I'm no longer on the iTalk board, but I am on the ATA board. I'll be sure to update that next year. So anyway, okay, so let's get started because I have a fairly long talk. I know most of the people in this room, and so I know that you already know what's on this slide, which is that anaplastic has the worst prognosis of all the thyroid cancers. It's a rare disease. And when the patient's diagnosed, sometimes it takes a while to diagnose them, but by the time they're diagnosed, oftentimes the tumor cannot be removed without like just removing, larynx and doing a very radical surgery. And then half of the patients already have metastatic disease. And the other half that don't have clear metastatic disease probably have micrometastatic disease, meaning I can't see it yet on the scan, but it's probably already escaped. And so this is a very big problem because even if you treat the neck, oftentimes patients ended up dying of metastatic disease. And then most patients are older, but we are seeing a trend of younger patients. And I know there are probably a couple out there on the video. Our youngest patient has been 32 years old. And so it's very rare. Usually we're talking about patients in their 50s and 60s and older, but we are seeing patients in their 40s and 50s when they present. So this tumor is classified as stage 4 because the risk of dying of anaplastic thyroid cancer is higher. It's a very aggressive tumor. And the classification is very easy. We have A, B, and C. So 4A is that it's just in the thyroid, and those are usually found incidentally. The patient didn't know they had anaplastic, but they had a surgery that showed that on the pathology. Those patients do the best. Then the 4B patients, which is the middle one here, are patients who have disease that has not escaped the neck, that you cannot see that has escaped the neck. But it's invading some of the structures of the neck, or it's in the lymph nodes. It's gone past the thyroid gland. And then 4C are patients that have distant metastatic disease. And then what I think has really changed lately is that we have to classify our patients not only by stage, but we have to classify them by whether they have a BRAF mutation in their tumor or not. Okay, so this talk is about either the BRAF patients or the non-BRAF patients, which are a bit of a heterogeneous group. But you have to know the stage of the patient and you have to know the BRAF status. And so we're going to talk about how to determine the BRAF status very rapidly because it's a rapidly progressive cancer. Now, I think there are patients in this room that don't have anaplastic thyroid cancer. And I think this is a very beneficial slide to everybody here because what it shows is that you start out with a thyroid, right? A normal thyroid here in the center, the pretty butterfly shaped gland. And then from there, you can have two major classes of tumors that develop. On the left are tumors that develop from C cells, which results in medullary thyroid cancer. On the right is what we're mostly talking about today, which are the cells of the thyroid gland that that concentrate iodine, that make thyroid hormone. Those are called the epithelial follicular cells. And from from there, you can get 3 types of cancers: papillary thyroid cancer, follicular thyroid cancer, and Hürthle cell, which is now known as oncocytic thyroid carcinoma. These tumors, especially papillary, have, particular mutations and fusions. And then as the tumor gains more mutations, that usually happens over time, sometimes due to treatment, then you can have a tumor that becomes less and less like a normal follicular cell. So these tumors are kind of in between a differentiated thyroid cancer, which are these 3, and an anaplastic thyroid cancer. And this is a very heterogeneous group. So the patients who have poorly differentiated thyroid cancer that behave, have kind of very slow growing disease, and there are ones that behave almost like anaplastic thyroid cancer patients. And then as these gain even more mutations, they can turn into anaplastic. Now, this actually wasn't known when I first started treating thyroid cancer. We did not understand that these tumors actually are derived from more well-differentiated tumors. And not only that they're derived from that, but what happens is that the mutation that started out the tumor, let's call it BRAF here in papillary, you still retain it as in anaplastic thyroid cancer, in poorly differentiated anaplastic. So that these tumors are genetically still, they resemble the differentiated thyroid cancer from which it came from. That makes sense? Okay. That's a very important point that I don't think that we really understood and until more recently. So the survival of these patients based on mutation is very different. And, our understanding right now is fairly basic. We know that BRAF V600E mutated tumors, because these patients have tumors that have a matching drug, right? A kinase inhibitor drug that can target BRAF. Those patients do the best. This is a survival curve. The higher the tail, let's say, the better. Patients that have a RAS mutation have the worst prognosis, and then those that have neither BRAF or RAS are somewhere in between. So we've done pretty well with raising this curve, or raising the tail in BRAF. We're making some progress in these other tumors. That's what we'll talk about today. Okay, so a lot has changed, and in the 2021 guidelines, which now really do need to be updated, had not been, the previous version was 2012. So because nothing was happening in ATC until more recently. So basically, if you read the 2012 guidelines, it's the most depressing thing you'll ever read. Don't read them. Promise me no one's going to read them, because all it talked about was putting your patient in hospice and it was doom and gloom. And that has really changed. And so we no longer just put our patients into hospice like what was being done before. And also, what's really important, knowing the BRAF status, right? You have to know if the patient has a BRAF mutation in their tumor or not. So I'm going to talk about these emerging therapies. The guidelines really do need to be updated, so they're not all that useful right now. Okay, so in 2011, all we had was surgery, radiation, chemotherapy. That's all you did for anaplastic. And sometimes you didn't do any of these because you just put them in hospice. And then in 2014, we made this leap of faith where we said, okay, we're going to see, we had this protocol, right, for what's called a basket trial for patients that had a BRAF mutation in their tumor. And then they had a basket for each type of diagnosis. So they had cholangiocarcinoma, and they had anaplastic, and they had others. And so we opened this study at MD Anderson. We quickly found out, though, that it was going to be difficult to enroll this study. Well, why? Because with anaplastic, you have to go very quickly, right? But but this slowed us down significantly because we had to know the BRAF status, right? And so it wasn't so easy to treat these patients. So we realized that we needed to figure out a way to identify these patients quickly. And so now we know that when you're treating anaplastic, you've got to figure out very quickly what the mutation status is for BRAF. And so we started doing this by immunohistochemistry, which is just staining a slide. Okay. It's kind of like an immunostain, like any other immunostain in pathology, which I'm sure you're not that well aware of, but it's a pretty easy test. Turnaround time is 24 hours if you have the antibody in your hospital. You can also do it by PCR, which is kind of a quick and dirty single gene test. And then you could do it by liquid biopsy. The gold standard is to do like a DNA based test on the tumor, but that at the time took like it took about 21 days back in 2014. It's gotten much faster. And so that wasn't adequate. And then we also introduced liquid biopsy, which gave us a result in maybe 10 days, but still fairly slow. So the immunohistochemistry option was very attractive to us because we could identify patients very quickly. This is just showing you what liquid biopsy means, which is that the tumor actually sheds some of the genetic material into the blood, and then you can sample the blood instead of sampling the tumor and then run the test on that. And that usually works pretty well in anaplastic thyroid cancer. So those were the two tests that we had really initially, was the immunohistochemistry and that blood-based test. This is just showing that we now have this in the guidelines. So this is one of the major accomplishments, I think, that has occurred, is that we now say you have to do this genetic profiling and you have to do it early. Okay, so that is how to diagnose the BRAF. Now I'm going to talk about how we think about anaplastic thyroid cancer nowadays. So you're dealing with a tumor that is very large in the neck and oftentimes cannot be removed surgically. And that tumor is pushing on the trachea, is pushing on the esophagus. The patient can't breathe very well, oftentimes can't swallow, gets dehydrated. So the very first thing you have to do is to reduce the volume of that tumor, which we call cytoreduction. It's just a fancy word. It says make it smaller. Because if you make it smaller, then the patient feels better. And maybe you can even take it out. Okay, so that's the first step, and it has to be done very quickly. The second is that you have to, you have to figure out a way so that the tumor doesn't outsmart you. And what happens is that you start getting these cells that are resistant to whatever treatment you're giving the patient, and you want to actually prevent that from happening. So that's the second step. The third step is to, if you can take it out, take it out. If you can radiate it, you radiate it. And I'm going to go over each of these. I'm just giving you a bird's eye view of what we're going to talk about. And then we need to monitor for residual disease. We still don't know how to eradicate minimal residual disease, but that's something that we're working on, and I'll talk a little bit about. Okay, so let's first start with the patients with 4A disease, which you just take out, and non-BRAF mutated 4B disease, which are the patients that just have tumor in the neck, but you might be able to take it out, but you may not be able to take it out. Okay, so what we do with those patients is we determine, can the patient have surgery, yes or no? If they can have surgery, they go to surgery. And then afterwards, we give them radiation to the neck, right? This is nothing new. This is nothing novel. This is what we've had for a long time. There are patients that cannot have surgery, which we call unresectable or inoperable patients. And those patients go directly to radiation, okay, because we can't take out the tumor. This is for patients that do not have a BRAF mutation. We're not talking about BRAF mutated here. And then what did we used to do? We used to just say, okay, come back every 3 to 6 months and we'll see what happens. But we already know what happens. We know that in 70% of patients, they're going to either have a new metastasis somewhere in their body, or the tumor in their neck is going to start growing. So why are we waiting? Like, it just doesn't make any sense, right? But it's because we didn't really have any tools that were particularly helpful, but now we do. So now we have checkpoint inhibitors, which is immunotherapy. It's a class of immunotherapy. Probably a lot of you are on Keytruda or pembrolizumab. Probably most of this room has seen this drug. And what we give this to patients who have had their upfront treatment, either surgery, radiation, or directly to radiation. We then put them on immunotherapy for 1 to 2 years. And we have the data now on this that we're going to present it at the American Thyroid Association, but it's under embargo, so I can't talk to you about it. But it looks good. So that's all I can say. So, okay, now let's talk about the BRAF mutated patients. These are patients that we have had the most success with to date. That study that we did in 2014 resulted in the two drugs, Tafinlar or dabrafenib, and Mekinist or trametinib, and being approved by the FDA in 2018. And that's because we saw so many responses. So each one of these bars is a patient, and the bars that go all the way down mean that we can no longer see their tumor anymore. That's called a complete response. The ones that are past this gray line are patients who've had a partial response, meaning that their tumor shrunk 30% or more. And then the ones that are above the line or getting bigger are patients that have, these are stable disease. The pink or kind of reddish color are patients that have progressive disease. So you can see that of these 36 patients, the vast majority had a response. Okay. And that response, the only problem is that the response doesn't last forever. Okay. And that's our problem, is that the tumor can outsmart these kinase inhibitors. That's the case in all cancer. And so our median overall survival was 14.5 months. What does that mean? It means that half the patients have died by 14.5 months, and the rest of them are still alive. And so that's a measure that we use in oncology to determine if something looks efficacious. The median overall survival before the discovery of dabrafenib and trametinib for anaplastic thyroid cancer was very, very short. In patients who had distant metastatic disease, it was about 3 months. Okay. So going from 3 months to 14 months, it was like a miracle. The problem though is, so first of all, this was very slow. It took 4 years to enroll in 9 sites. But we got it done. But here's the problem. After 6 months, these drugs stop working for many patients. And you see each line downwards, right? These vertical lines means that a patient has died. So you're seeing a lot of patients dying very early on, and some of them surviving. Okay. And so that's just not good enough, right? Because we don't want our patients to die. And so the question is, how do you raise the tail of that curve? We want this line to be up here. Up here would mean everybody gets to live. Okay. It's probably unrealistic, but I think we've done a pretty good job of getting the tail up. This is the reason why patients die. This is a patient that has a tumor on her scalp. It goes away completely on dabrafenib and trametinib, and then it starts to come back. You can see it here, and then it starts to really come back. And then this patient, we took her to surgery. And what happened was that when we looked at her tumor and compared it to the original tumor in her thyroid, the original tumor had these 3 mutations. The tumor that came out of her scalp that was resistant had acquired new mutations. And this one in particular, RAS, we just talked about, has the worst prognosis, right? So this patient, luckily we were able to remove the tumor, but in many patients we're not able to. So you need to prevent this from happening, because if you don't prevent it, then you are in a real bind in terms of treating it. So how do we avoid this? Well, you have to understand a little bit about what is happening here. We actually don't know. But these are the 2 possibilities. One is that you have this BRAF mutated tumor in blue, and then you have these little cells in yellow that are something else. They don't have a BRAF. They have some other mutation. So the tumor, the majority of the tumor shrinks, and you're so happy. You tell your patient you have partial response. It's wonderful. Let's just keep going. And then all of a sudden, the patient comes back, and those yellow resistant cells have taken over. The other possibility is that you have a tumor that is just BRAF mutated, and that during treatment, these cells emerge that maybe have acquired a new mutation, right, and are able to grow and grow and grow up and outsmart the drug. So probably the what's happening is the escapee theory is probably what's happening, is that, you know, you've got some cells that have developed new mutations and can no longer respond. So we want to prevent this from happening, and you can prevent that by doing two things. One is that you can take out the tumor. So you can just take the patient to surgery now because the tumor is much smaller, right? So you can remove it, or you can add immunotherapy, because immunotherapy is not targeting the tumor at all. It's actually targeting your immune system, and it's explaining to your immune system that it needs to wake up and go after the tumor. So it's like training your immune system. And so, you know, that may work on cells that are becoming resistant, right? But really, probably the best way is to do a combination of these things, which I call the kitchen sink. So I'm going to skip over this one. So these are our data that show that that if you start with the BRAF-directed therapy and then take out the tumor, patients survive longer. Okay, so here's our little curves again. Remember, tail up, right? We want that tail way up. This curve shows the patients that had BRAF-directed therapy first, then went to surgery. It was a mixture of patients that had maybe immunotherapy or didn't have immunotherapy. But the point is that compared to the patients that had surgery and then BRAF inhibitor, or had no surgery and just BRAF inhibitor, these patients did the best. You want to be up here. You know, you don't want to be any of these patients that died. You want to be up here in the curve in the horizontal position. Okay. So we did a great job. The guidelines allowed us to put in there that BRAF mutated patients with 4B disease should have might have upfront BRAF inhibitor and then surgery as a possibility, instead of going directly to radiation if you can't take it out. So we want this to change a little bit, because we like stronger recommendations for starting with a BRAF inhibitor. And we also think that the 4C patients, the patients with distant metastatic disease, they also benefit from that strategy. So it shouldn't just be the 4B patients. Because in theory, right, everybody has micrometastatic disease. So why not treat them all the same? Because many patients die because of not being able to control the tumor in their neck. And so, you know, we want to try and avoid that recurrence in the neck if possible. Okay, so the other strategy I talked about is to use immunotherapy. We have data on patients who were in a trial who were just on immunotherapy, nothing else, just single agent checkpoint inhibitor. In this case, it was a drug that never made it to approval, called spartalizumab, very similar to pembrolizumab. And the response rate was only 19%. Who thinks that's a good response rate? 19% of patients responded. No? Okay, me either. Oncologists thought that was fantastic. I was like, really? Okay. So your standards are pretty low then. The median overall survival was only 6 months. And it turned out that patients who had high PD-L1 expression, that's the target for this drug, right? It's targeting PD-L1 on the tumor, right? And it's attracting the immune cells to go to that tumor. The patients that expressed that marker, which is the target for spartalizumab, did better. So those are the ones that are in the tail, have a higher tail right here. Okay. Okay. Versus patients who didn't express PD-L1. But it turns out that the vast majority of patients in the United States have PD-L1 expression. It's very rare to see an anaplastic patient that doesn't. So we just treat them all the same with the checkpoint inhibitor. We don't wait for the result is what I'm trying to say. Okay. So we think that we need better outcomes here. And so we decided that combination strategies were probably the best way to go. I'm going to show you this data very quickly that Dr. Sarah Hamidi worked on very hard over the past year or so. And it just shows that the combination of the dabrafenib, the BRAF-MEK inhibitor, plus the immunotherapy is better than just giving patients dabrafenib without immunotherapy. So these are the ones that had the triplet combination, 3 drugs, immunotherapy plus the targeted therapy are in that purple line. And you see that the tail is higher than patients that just received the 2 drugs alone. And then the patients that had neoadjuvant therapy, those are the patients that we gave the BRAF-MEK inhibitor to upfront, and then we took them to surgery. Those patients had the best survival of all of them. It was a median overall survival of 63 months. So that is our algorithm now. I'm not going to bore you with these details because this is all published in JAMA Oncology, just came out over the summer. Essentially what it says is that if you have a BRAF mutation and you haven't had surgery, you should start with BRAF inhibitor, MEK inhibitor, and then go to surgery. And that works very well in the majority of patients. Rarely we have patients where it doesn't work. They're rare patients, and we're studying that right now. Okay, so stage 4C non-BRAF mutated. So this is what a lot of people are really like dying for us to figure out what to do, how to manage these patients effectively. And that's where we're very much focused on these days. And we again go back to this same strategy. It's the same strategy, right? Where BRAF mutations, we did rapid cytoreduction with the BRAF-MEK inhibitor. Here, we're looking for something that, because these patients don't have a BRAF, something to shrink the tumor very quickly. And we have a couple things that we're thinking of. Radiation combined with immunotherapy and targeted therapy or fusion-directed therapy. We introduce our immunotherapy, of course, to prevent resistant clones. And then maybe we can operate on the patient and then give them the rest of the radiation that they need. And then, of course, monitoring and then eradication of minimal residual disease, I'm going to talk about for both diseases. So we did a study of lenvatinib as single agent in the United States, and it did not work. Single agent did not work. The single agent just doesn't work, period. It'll work for a little bit of time. It doesn't work enough. It doesn't work long enough because these tumors are very much able to figure out a way around your inhibitor. And if you use just one strategy, they're going to find a way around it quickly. If you use 2 strategies, it'll take a little longer. If you use 3 strategies, it'll take even longer, right? So we have to use combination therapy in these patients. We're going to have a little bit of data coming up at the American Thyroid Association that we're presenting on patients with these fusions who have anaplastic thyroid cancer. And there's going to be some data on combination therapy in those patients also. Okay, so lenvatinib pembrolizumab is the best thing we have right now for non-BRAF mutated disease. We opened this similar trial, but the Germans beat us to the punch and enrolled it while we were, at a dead halt during COVID. They ran with it, and they were able to enroll a good number of anaplastic patients and show that the partial response rate was 52%. Pretty good, right? I mean, much better than spartalizumab. So 52%, there were no complete responses, but, so it's not as good as the BRAF-MEK inhibitor, but these look pretty good with combination lenvatinib with pembrolizumab. The median overall survival was 11 months. Okay. If you compare that to single agent lenvatinib, it was only 3.2 months for single agent. Okay, so this is probably the best that we have now for systemic therapy, but we're starting to see some interesting things. Radiation, when you deliver radiation in the beginning, you cause these tumor cells to open up and spill out what we call antigens. They're, different proteins and whatnot that the immune system goes, oh, that's not supposed to be there. Let me go clean that up, right? If you keep giving radiation, right, if you go up to high doses, what happens to those immune cells that are coming in? You kill them. That's what happens. So we asked, well, what if you give a lower dose of radiation that stimulates the immune system? So now your immune system's going, that's not supposed to be there, attracting immune cells into the tumor. And then you deliver a second punch with lenvatinib pembrolizumab. So this is just an example of a couple patients. We're now doing this actually formally on a trial. And we're going to open a second trial that has this strategy in it. But this is an 80-year-old man. He actually didn't look 80. He probably looked about maybe 65. Very healthy man, has no BRAF mutation. Okay. And a very large tumor in his neck here. And then these two other lesions in his lungs. These are his kidneys. They're supposed to be like that. This is his ureter. You can ignore that. That's the brain. Also ignore that. 1, 2, 3 problems here. We gave him low dose radiation. We give him a half dose. Usually we go up to about 60 gray of radiation. And we gave him half the dose. Why? Because giving 60 gray of radiation costs you 6 weeks of treatment. And then you can't do anything else. You can't give these other treatments. So you shorten the treatment, stimulate the immune system, but don't kill the immune system, the local immune system. I'm not talking about like your bone marrow. I'm just talking about the immune system in the tumor. And we also give him a little radiation here to this bigger lesion. And then we put him on lenvatinib pembrolizumab. So you see that compared to baseline, his tumor is much better, still has some activity. And this little tumor, this big tumor is smaller. I'm not actually sure. Yeah. And then I think this is the other one, or it's disappeared or something. Anyway, the thing is that we took him to surgery, and this is really the interesting part. We took him to surgery, and the pathology came back, and I was like, what the well? Here, there was no tumor. No tumor. It was all dying dead cells and fibrosis. So fibrosis like a scar. Okay. And so we thought that was a very interesting finding. So because usually we don't see that. Even with the BRAF mutated patients, oftentimes we still see like some papillary thyroid cancer, although the anaplastic has died. This is another patient about half his age who had a RAS mutation. I believe some of you have this other mutation. And he had a tumor in his neck, and he had a tumor in his chest, and he also had a tumor in his adrenal gland. That's a little gland that sits on top of your kidneys. You have 2 of them. He had a metastasis in the left one. We gave him even lower dose radiation, 14 gray. So that's like, I can't do math, a quarter dose or something. And you see that his tumor, the activity in the tumor really goes away. But we didn't radiate this. It also went away, right? So this is on lenvatinib pembro. So you say, okay, well, maybe it's just a lenvatinib pembro, or maybe the immune system is now able to see that there's a tumor there. We don't know. But when we took out his tumor, again, we were just shocked. It had really no activity, and there were no viable cells, no cells that were alive that were anaplastic. So that's one strategy that we think is probably the best strategy for non-BRAF mutated patients at the moment. Although the fusion patients, I'm still on the fence on what to do with those patients. But I think that we have a combination that might be a viable combination that's very similar to what we do with the BRAF mutated patients. Okay, so so let's go through our cytoreduction for non-BRAF would be with radiation, low dose radiation, and then followed by lenvatinib pembrolizumab to get the tumor down. The immunotherapy for resistant clones, consolidate by removing that tumor, surgery, and then you can give more radiation, and then monitoring that we're going to talk about in a moment. Okay, so the other thing that we do is when you have metastatic disease and you can't really, sometimes like the tumors are starting to grow despite your chemotherapy. And so we started doing radiation for areas that were becoming problematic. And we do think that that is the way to go in patients that have kind of smaller volume disease, metastatic disease, is that you do maximal suppression of their cancer, right? You treat their neck the way we just said. You put them on chemotherapy. And then if you're still seeing stuff and it's just a small amount, 5 lesions or less, maybe just radiate all of those if you can, right? Get them down to the smallest volume of disease possible. Why? Because the patients that do best are the ones that start out with minimal disease. The patients that have larger volume disease have, it's much more difficult to see very good responses in those patients. So we looked at our patients. There were a bunch of patients. We had, like 96 patients, all types of thyroid cancer. Anaplastic was about a quarter of the patients. And this is the result for the anaplastic thyroid cancer patients. These are patients that were having, that were starting to, like had little things in their lungs that were starting to grow, and then we zapped them. And those patients, from the time of doing the little zapping in the lung mostly, had an additional like median overall survival of 14 months. So, so we like to try and address everything that we can see that's reasonable to address. Okay, so again, now we're going to talk about monitoring of minimal residual disease and maybe a little bit about eradication. So monitoring of minimal residual disease. So now we've treated our patient, they've done great. They're just like, okay, now what do I do? Because I'm on these drugs and you're telling me that it's not going to last forever. What are we going to do now? And so, and maybe we've like zapped everything we can, but we're all very scared. It might come back. And what I think the strategy should be is, if you can detect the tumor coming back very early, then you can change your strategy. You're not letting those tumors become big enough so that so they become a problem and so big that you can't treat them. I can't scan you every day to find out when your tumors are going to grow, but I can do a blood test on you every however many weeks. Nobody knows what the ideal is. You can do it every 6 weeks. You can do it every 12 weeks. It depends. You can do it every time you do a CT scan, which is 8 weeks. But basically what we're doing is using a commercially available test called Signatera. And what this company, Natera, does is that they take your tumor, the tumor that we biopsied in the beginning or maybe took out of your neck, and they're making a test that's specifically based on your tumor. Okay, so it's an individual test. You can't get more personalized than that, right? Nobody else is having the same test as you, right? And then they're checking your blood every so often, however often we order it, and looking to see something, because they won't tell us what, that's based on your tumor that tells us that your tumor's back. That makes sense? Okay. And we call that molecular residual disease. That's what we're checking for. Molecular residual disease, because they're not looking for your actual tumor cells. They're looking at something from your tumor, molecular wise, that we can see now in your blood. And so when you see a blip up, you go, oh, there's something going on here. Okay, so this is just showing you, this is actually what I should have shown you, which is here you are, and you have this tumor that we removed, chop it up, make a special test for you, and then longitudinally we follow that blood test. So here's a patient that had detectable levels, what we call ctDNA, and then drops down to 0,000 after surgery. That's an example. This is actual real life patient of ours who started off, oh, I thought I had taken the dates out. Yeah. So started out great, no detectable tumor, and then it starts to blip up, and then it really starts to blip up. And we are like, got to do something. So we put the patient on a therapy, and then it goes back down to 0. So at this point, right, we could already, we were like, there's something going on, go get a scan. And then we could see it. We could see that it was there. And I wouldn't have caught that early. Okay, so so that's what the Natera is. And some of you are doing this test, a lot of you in this room. And we're actually trying to see if we can take you off your BRAF and trametinib because you've been on it for years now. And so, we're wondering, like, how long do you have to hit that tumor until it's gone? And the answer is, I don't really know. But if I don't see anything for years and years, like, we ask ourselves, well, how long do we need to do this? And we think that Natera test, that called Signatera, could help us monitor for the disease coming back. Okay, so what else is exciting out there? Well, this is actually pertinent for BRAF mutated and for non-BRAF mutated. This is the CAR Ts. Many of you heard of CAR Ts? Yeah. Yeah, and there is a talk tomorrow by Dr. Short. So I told him I'd introduce it to all of you so he wouldn't have so much trouble explaining it. So what we've found, and this was actually Dr. Fahey's lab in Cornell, found that, that ATCs and poorly differentiated, and probably some papillary thyroid cancer patients, express a protein on the surface of the tumor called ICAM1. Okay. And so he built a CAR T. CAR T is cellular therapy. It's an engineered T cell. T cells are part of your immune system. They take those T cells from you and then they engineer them. And then they give them back to the patient so it can recognize the tumor. And so he discovered this CAR T that's directed against ICAM1. Interesting. This is a very special CAR T. This is very different CAR T from any other CAR T in existence because there are CAR Ts for all kinds of cancers. But this CAR T, he's brilliant because what he did was that he made it also the cells that are removed from the patient, right? He engineered it so that they express something called somatostatin receptor 2. What is that? Well, it's a target that a test called dotatate PET could see. So it traces the CAR Ts. Basically, we're able now to, with a PET scan, not your regular type of PET scan, it's dotatate PET, can see where the CAR Ts are locating to, right? Because you used to just give CAR Ts, or you still just give CAR Ts and just kind of see, well, okay, what's going to happen in a few months? Either the tumor goes away or it doesn't, and you have no idea where these CAR Ts are going. Are they being eaten up by your immune system? Like what's happening with them? We can actually now trace them with this CAR T. So it's a very cumbersome treatment, okay, as all cellular therapy is. You have to, what we were doing before is that we were screening the patients to see if the tumors express ICAM1 or not. That took a long time, 6 weeks or so. We're enrolling the patient and then we're removing your white blood cells, not all of them, just some of your T cells, giving you back the rest of the blood, right? Because we take out the blood, separate out the T cells, and we give you back the rest of it. And we send those T cells off to the lab. Affiimmune is the sponsor of the study, and they're the ones that engineer those cells. They grow those cells, okay, while you're waiting. Those cells are now being grown, expanded, and then they're being re-engineered so that they can find your tumor. Okay. So that it's locating ICAM1 on your tumor. It's trying to take these engineered white blood cells to your tumor so that it can destroy the tumor. And then the patient then is admitted to the hospital, and we give them a little bit of chemotherapy to tamp down their immune system so that the immune system doesn't destroy the CAR Ts. And then we give them the CAR Ts, and then we do all these different tests. Okay. So this is quite a process because you have to be admitted to the hospital and all of that. And, nobody likes that. And you also need the luxury of time, right? Because you need the 6 weeks that you're waiting, or you used to get the test results back. You had to wait for the manufacturing, and you had to be admitted to the hospital. And by the way, there's a wait list. So this requires a lengthy amount of time. So you have to have a patient who has very little disease so that if it grows during that time, we also have to take you off your chemotherapy at admission. So if it grows during that time, the time that you're off your chemotherapy, you have to have a small enough volume of disease so the tumor doesn't kill you, right? So we're trying to find patients that have small amount of disease that we think maybe if we do this, could we cure the disease? Could we just get rid of all of it? And so that is the goal, and that's what's being studied, where this is an example of a patient on a very low dose of CAR T. I'm going to quickly go over this, but basically this is the tumor. We have the dotatate PET, which locates where the CAR Ts are. Patient hasn't received CAR T, so we don't see it. Patient receives CAR T. We see that the tumor actually gets bigger, probably because white blood cells are in there, and white blood cells take up space, and it looks like it's bigger. But we're able to say, yes, the CAR Ts are in her tumor, and then her tumor starts to shrink. Okay. And then now we can't see the CAR Ts anymore. So this was a very low dose. We're now at a higher dose, and we're staying at the 500 million dose level, and trying to enroll more patients. I'm going to skip over this because I'd like to answer some questions for you, but this is our FAST team. Many of you know these doctors. These are the great doctors that treat anaplastic thyroid cancer. This is an expansion of it because we've got our radiation oncologists here. We have our translational team that does all of our mouse data and computational data. And then this is we had an 80th anniversary fundraiser where we were able to raise funds to do many of these trials. And then we also received some funding from these different groups. And of course, I want to thank all of our patients who are brave enough to weather the weather in Houston and come and see us. Thank you.
Could you talk about the results of what you've seen in the CAR T cell trials, how successful they've been, how many patients you've enrolled?
Yeah, I don't know the exact numbers, but what I was explaining to another patient is that this was a phase 1 trial, which means that you started out with a very low dose and then you work your way up to see what's the safe dose and the efficacious dose. So now we're at 500. I don't remember how many patients we have at that dose level. I don't know, what do you think? 5, 6, but then there are some at other sites. Yeah, but there are some at higher doses. Yeah. I mean, it's probably fewer than 10 patients at 500. No, just overall. Yeah. So, I mean, you have to think about how many patients do you have at the dose level that's safe and effective, right? Because these other doses, you're just giving like baby amounts of CAR Ts, and that is probably not good enough. So it's still very early. And of those patients, we have, I think, 2 anaplastics that have responded. 2 anaplastic patients that have responded. Yeah. We're doing 500. Yes. But we started at very low doses. Yeah.
Okay. Any other
I've got a
in-person
question.
questions?
Oh, in person, sorry.
Can bring you the mic. Yes.
Differentiated
in this clinical trial?
Yes, there are, because it's for poorly differentiated also. However, you know, what we've observed, so we sit down, Dr. Hamidi has a conference where we sit down and we review every one of those patients, not just CAR T patients, but a lot of our anaplastic patients, especially like our non-BRAF mutated, to see what's working and what's not. And what we're seeing is that, you know, the poorly differentiated thyroid cancer patients tend to have a lot of disease, right? Because we think of poorly differentiated as like, oh, they can tolerate being off their chemotherapy for a little while, as you know, they're slower growing. But I think in reality, they're not. I don't think that they can tolerate being off their chemotherapy for a long time. And so my thought is that we need patients that have lower volume disease overall, even the poorly differentiated thyroid cancer patients. We've seen some interesting responses in poorly differentiated. You know, I just think those are not the right patients. I think this is meant to be to eradicate small amount of disease that we cannot get with anything. We can't get it with the chemotherapy. We can't make it go away. And I think patient selection is going to be very important. So we're going to try and focus on patients that have smaller amount of disease that we think could be cured with CAR Ts, rather than a lot of disease where these cells, they're not magic, right? There's a finite number. They do expand, but they get exhausted. Like if you have such volume of tumor, they can't eradicate all of that. So I think this patient selection is going to be important. But I think this is like the next thing as a step to actually cure patients. I think we have cured some of the BRAF mutated patients, and this could help those patients too that haven't completely had, complete responses of their disease. But it's also like a really big step with our anaplastic patients that don't have a BRAF mutation.
Any others?
Thank you. Great, Dr. Cabanillas. We come from California, and we came to MD Anderson, and we found that you had a fast track program. You utilized ctDNA, all state of the art. And we come from a good hospital in Southern California. They don't do that. And most others, almost all don't do that. How do we in society get them to spread that technology, to spread the issue of trying to get faster diagnoses and start the treatment plans in our society at this point?
Yeah, that's been actually one of our biggest challenges that we're trying to address right now. So Dr. Iyer, who I think she's going to have to switch to Zoom because she was feeling under the weather, is she? It was earlier today, I'm told. But Dr. Iyer has just opened a study called Grassroot, which basically is taking all of this information to other centers, and not just in the United States, but also in other countries. We're just starting. So we're starting with our local community hospital, not community hospital, public hospital in Houston. But we're going to be adding sites. And so that as we learn, right, and start publishing that, we're also giving these sites, like, this is the way we're doing it, this is what we think works, so that they can do it at their site. So, because it's very difficult with a rare tumor to disseminate that information. You have to understand these oncologists are trying to figure out how to treat every type of cancer. A lot of these are general oncologists. They treat breast cancer, they treat lung cancer, they don't treat anaplastic thyroid cancer. They've seen maybe a few in their lifetime. You're asking them to, keep up to date on a super rare tumor, and that's just not really possible. So we think that this is probably the best way to do it, is that we actually have a protocol in place in these different centers that patients can reach. Not everybody can reach MD Anderson.
Okay, we have a few virtual attendee questions. Do we have a virtual host that you could ask the question for your audience? Okay. Do you anticipate that some of what you are learning in ATC treatment will become adapted for PDTC? If so, what?
Yes, I do. We will eventually try. I think the biggest issue is that we already have these approved treatments in poorly differentiated thyroid cancer that you kind of have to try first. And so it's a little bit more of a challenge. Whereas when lenvatinib alone didn't work in anaplastic, we were just like, oh, well, the obvious thing is then to combine it with something. Whereas in poorly differentiated, lenvatinib works very well. It just doesn't work forever. And now maybe adding immunotherapy is the right thing to do. And that, has been studied in a trial. But in order to get that as the, approved treatment would require a whole clinical trial. And I think that's the biggest challenge, is getting this accepted as a treatment based on data, right? Because that's what you need essentially to be able to use these drugs.
Okay, and then there's just one more. Virtual, do PDTC patients 14 plus years out after multiple TKIs qualify for CAR T treatments? Is there concurrent trial in NYC? Would someone with an autoimmune disease in remission like ulcerative colitis qualify?
I don't think autoimmune diseases would disqualify a patient for CAR T. Unfortunately, even though the study started at Cornell, Cornell's site actually has closed. And so and it's not at Memorial Sloan Kettering. So there are no sites in New York City right now, only MD Anderson, Northwestern Chicago, and City of Hope, California are the ones that are open in LA.
Okay, are there any more in-person questions? And I'll bring the mic to you before it's almost time to conclude the session.
Nobody wagged their finger at
Okay,
me.
here
I'm
we go.
surprised. That means you understood everything?
Yeah.
Incredible.
How quickly, if, like in our case, you are able to do surgery and there is no distant disease, how quickly do you anticipate, if there is going to be a reoccurrence, that a reoccurrence will take place? I think
Yeah.
we've talked about
Yeah.
this. I like your answer, so I just want to hear it again.
Yeah. So we think that if you make it to 5 years with, your PET scan is negative, you have, if you're doing the Signatera test negative, it's very rare to see recurrences after 5 years. I've seen one, and I can't really prove that the patient didn't have it before. It wasn't my patient. It came to me after the recurrence, so I don't know for sure, but it's pretty rare after 5 years. Usually we still follow the patients, but maybe we don't need to follow them every 3 months like we do with patients who are in remission.
Okay, well, this concludes our session. And we so much, we thank Dr. Cabanillas